Good afternoon, everyone. Thank you for making the time to join us this afternoon. I am Dr. Bachan. It is my pleasure to be moderating this session. It gives me great pleasure to introduce our speaker this afternoon, Dr. Lawrence Amsel. He is an associate professor of clinical psychiatry at Columbia University. He is also an associate director of the Global Psychiatric and Epidemiology Group, or GPED, where he applies physician science tasks in psychiatric research and explores the role of biological mechanisms and decision science to a range of outcomes, including suicidal behavior. He's an outstanding teacher. He also trains clinicians, especially pediatricians across the US in psychological assessment and treatment. He has trained thousands of community clinicians in evidence-based treatments for PTSD and complicated grief. He is also a co-investigator for the GWP and the GRID programs here in Guyana. This afternoon, he will be going through an introduction to depression and anxiety. And so it again gives me great pleasure to introduce him. Dr. Amsel, thank you for being here, and the floor is yours.
Thank you. So we're going to be talking about introduction to depression and to anxiety. And this is for primary care clinicians and family clinicians. I'm going to be talking about children and adolescents. It generalizes much more easily to adults than if we only talk about adults and try to go back to kids. So we're going to talk about this for kids. And this comes out of a program and the REACH Institute, which has been running these programs for 15 years. And the goal of the REACH Institute is to reach out to primary care clinicians primarily in the US. We've been doing a little bit internationally, but primarily in the US, where we've trained over 5,000 primary care clinicians. And when we started doing this, it seemed like a very strange idea. Nobody was on board with this idea of training primary care clinicians to do mental health. Now it's become a much more, I think, common and accepted idea that in order to really meet the mental health needs in the United States, and even more so elsewhere, because in the United States, we do have more psychiatrists per capita than a lot of other places, but nevertheless, if you look at all the people doing mental health, psychiatrists, psychologists, social workers, nurse practitioners, we still don't have enough people in the United States and certainly other places. So this has become a really terrific model of utilizing the fact that we have trained clinicians. They may not know mental health, but they do a lot of things. And therefore there is a way of getting their skills up in mental health. And that is one of the best ways and quickest ways of increasing the person power who are doing this kind of work. So the goal is that those taking this course will become those taking the full course. Today, I'll give you a taste with 2 lectures out of our whole weekend. But the goal is to become more comfortable assessing and treating mental health cases in primary care. And we have found that primary care clinicians indeed do become much more comfortable based on these on this training. So the full program is a 3-day workshop, and then it is followed by 6 months of virtual rounds, which means small groups get together and they will talk about actual cases. Maybe we can institute that in the future in Guyana as well. But for today, we're just going to give you two of the central lectures as a sense for how this course works. So our learning objectives is to review depression assessment and treatment based on the American Association of Pediatrics approved guidelines, which are called the GLAD-BC guidelines. And the GLAD-BC handbook is available for free at glad-pc.org. So if anybody really, please write that down, because it's this wonderful handbook which will tell you everything you need to know about treating a depression in the primary care. Wonderful, it has wonderful things in it. I'll talk about it later. We're going to learn how to score and interpret standardized screening questionnaires, how to review diagnostic criteria, and then we'll summarize how to do treatment. How frequent, and this is again, I'm giving you United States statistics. In kids, depression is about 2% of the population. In adolescents, it doubles to about 4%. And interestingly, in adolescents, it doubles more in females than in males. It goes to a 1-to-2 ratio, whereas in younger children, it's not. It's a real burden of illness. We know that. There are much higher rates in primary care. There are high rates in primary care depression. And most of the kids, 50% of the kids who actually come into a clinical setting and have depression are missed. Someone has another conversation. Please, if everybody remembers to mute themselves, it'll be easier to hear. Thank you so much. There is the high family loading for it. It is something that is passed on through families, but there are also stressors. We know that abuse, childhood abuse, or neglect are precursors for later on having depression, and other disorders as well, anxiety disorder, substance abuse. There are a number of medical illness, primary diabetes and asthma, interestingly, also predispose kids to having asthma. Okay, so what are the adolescent mood disorders according to the DSM-5? There's more than one. There's major depressive disorder, which is what we talk about most of the time. There's also something called persistent depressive disorder, which is a lower level of depression, but it lasts longer. There's the unspecified type, which we have in a lot of DSM type diagnoses. There's this adjustment disorder with depressed mood, and that's when you don't have a full depressive disorder, but when something bad has happened, then you have a reaction to it. And then in other discussions, we'll talk about bipolar disorder and disruptive mood dysregulation disorder. I'm going to give those talks tomorrow. So how do we diagnose major depressive disorder? And the answer is there are nine major symptoms that we look for, and you have to have either one or two. You've got to have depressed mood or diminished mood. When we say depressed mood, it's either depressed or irritable. So if you ask an adolescent if they're depressed, often they'll say not, but if they suddenly are much more irritable than before, that is the same as being depressed as far as making the diagnosis is concerned. But you've got to have either one or two, either diminished interest in pleasurable things or the first one. And then, I'm sorry, I didn't mean to move yet. And then you need to have four more. So you have one of those, and then you have to have four more. Seems like a lot to remember, but actually there's a very easy mnemonic, which is just the alphabet, A, B, C, D, E, F, G, H, I, which is anhedonia, decreased interest, and bad mood. One or two of those, and then four of the rest: concentration, death thoughts, energy, food, guilt, hyperactivity or hypoactivity, and insomnia. So this is a really terrific mnemonic. You can just memorize this mnemonic when you start. If you're assessing a patient, you'll see that if you have this mnemonic in mind, you'll very rapidly be able to tick off whether or not they have sufficient number of these kinds of symptoms to make the diagnosis. Like all DSM diagnoses, there are other criteria in addition to the major ones that describe the symptoms. It's not better accounted for by other things. It's not due to biological illness or other kinds of things, but those are the rule outs. So how do we assess it? Well, the first thing is that you can take a look at an adolescence. If you're trying to assess an adolescent, you can just take a look and recognize the different moods in an adolescent. And here we have the different moods and the way adolescents present their different moods, i.e., adolescents don't express things very differently, right? So this is a happy and depressed. The adolescents look the exact same way across multiple mood states. One thing that has made doing this diagnosis in primary care so much easier is this thing called the GLAD PC that I mentioned before. It was a partnership between pediatricians, researchers, and pediatricians in the front line. They got together and they had a consensus workshop with 80 participants. And they produced this thing called the GLAD PC Toolkit, which is downloadable for free. It's a PDF. Anybody can just download it. And it has everything that you need to feel like an expert in depression for children and adolescents. It has psychoeducation materials for the children, adolescents, and their parents. It has patient family handouts. It has discussions about how to manage suicide, and it also tells you how to make the diagnosis. So what do the guidelines tell us? In the US, anybody who comes in 12 to 18 years old is supposed to be screened. In other words, every single kid who comes into a pediatrician's office, the expectation is that they should be screened. For those lower than 12, those only need to be screened if there's some reason for it. In other words, they come in with some kind of mental health presentation, or there's some suspicion you have. But again, for those 12 to 18, you're supposed to doing assessment for all of them. What are the screening and assessment tools? The one that we're going to talk about now is the PSC-17. This is an assessment tool that points out internalizing disorders. It catches all kinds of internalizing disorders. Those are depression, anxiety, anything where the kind of the suffering that's going on is quote unquote internal. It's not a child acting out, right? So that is a great screening tool. And as we'll see, after you've done that, you can follow up with a tool that's more specific for depression. So here's how our mental health evaluation tools can work together. You can start with a PSC-17, and again, that's filled out by the patient. If they're old enough to read it and understand it, then they can fill it out themselves, or a parent can fill it out. And then that has three, if it has a greater than 15 score, it has 3 sub-scores. There's a score for inattention, which would indicate to you that you might be dealing with PTSD, or you might be dealing, that you might be dealing with ADHD, or other kinds of inattentive symptoms. Then you have an externalizing subscale, and you have an internalizing subscale. So you get all of these subscales just from the PSC-17, and once you are in a situation in which I'll go over this in great detail, in which you think you're in internalizing disorders, then you can follow up with depression scales or with anxiety scales. And I'll go over this in great detail in a moment. So the PSC-17 is a psychosocial skills. It takes less than 5, actually takes, it says less than 5 minutes. That's when you start. It takes less than 2 or 3 minutes. There's a 17-item form, which we recommend. There's also a longer one. Ages 9 and up can usually do this on their own. It's a very quickly scored thing, because you can screen in or screen out people with a problem. What the research shows is about 12% of the kids who show up in primary care, in pediatric offices or in a family practitioner's office, about 12% will have a positive score on this thing. And so that's quite a large percentage of the people just coming in for any. They may be coming in for a sore throat, but nevertheless, about 12% of them will screen in. So on every item, the kid scores it as either never, sometimes, or often, which corresponds to 0, 1, or 2. And then you simply add up the numbers. If you have a total number of greater than 15, that's considered a positive screen. But in addition to that, the scale is cleverly designed so that, as I mentioned before, it has these 3 subscales. And for these 3 subscales, the attention subscale is positive if it's greater than 7, externalizing greater than 7, and internalizing if it's greater than 5. So you get an overall score that says something is wrong. Then you get these 3 scores, which tells you whether any one of these 3 subscales is problematic. So this is what it looks like, and filled out. And you'll notice we've coded it, because you'll notice that even though the questions are all mixed up, we don't have all the internalizing questions together or the other ones together, but they have a little code on the left, which obviously the patient or the family doesn't recognize what that means. But we know that each of those questions loads on. Does it load on to internalizing or externalizing? So let's give an example here. The attention subscale asks these questions. Are you fidgety, daydreaming too much, trouble concentrating? Do you feel like you're driven by a motor or easily distracted? And that one has the diamond scale. And you can see in this particular thing, there's a 6. Okay, so that the child or the parent filled it out so that the total thing was a 6, which is below the cutoff score. So that does not indicate, if that individual does not indicate that they have an attention problem. What does the externalizing subscale look like? This is acting out problems. And again, refusing to share, doesn't understand other people, fights with other children, blames others, does not listen, teases, or takes things that don't belong to her. And again, so you can see the square boxes represent that externalizing. And in this particular child, we see that there were no externalizing symptoms. What about the internalizing subscale? Feeling sad, hopeless, down, seems to have less fun, or worries a lot. So that's the internalizing scale. And in this child, there's a 9, and that is quite positive. So scoring the PSC, we showed you that particular example, which we're going to go to greater detail. What is, in this particular case, the total score was a 15, the cutoff score is 15. So they were positive for the overall. They said there is something wrong going on with this child. There's some problem. The attention subscale score is negative. It was only a 6. The externalizing was 0, is only a 6. But the internalizing subscale, pointing to depression and anxiety, that was a 9. So that is scoring positive. So I hope everybody understands that I not only in this particular child got a total score greater than 15, but it all landed on the internalizing. There was a little bit in the other ones, but it wasn't enough to actually indicate the internalizing. So this is telling you that you should be focusing not on ADHD, don't worry, put your focus on obsessive on oppositional defiant disorder. You should be concerned with depression or anxiety, right? So let's do a case example with Riley, okay? So Riley is an adolescent. He left the hockey team after he had a fight with a coach. After that, he broke off with his friends. He was isolating, even though he had a fight with a coach. And after leaving the team, he's isolating in his room, playing video games, skipping school, angry and agitated, poor sleep and appetite. And if you ask him, he won't discuss his suicidal thoughts. So what happens if we give this adolescent the PSC, right? So for Riley's score, there's a positive PSC. He scores 15. Again, this was exactly the case we talked about before, but without the background. His score on attention is 6, but that's not, doesn't make the cutoff score. His externalizing is 0. He is not acting out, but his internalizing is 9. So in that case, we do see that he has a total score that says he's having a problem. The attention subscale is negative. Externalizing is negative. Internalizing is 9. So we're strongly suspicious that he has an internalizing disorder. What do we do next? Well, as we mentioned, the next tool that we could look at is a tool that focuses down further on depression. So we could use the PHQ, and here is the PHQ. And the PHQ is really just reiterating the DSM symptoms that I mentioned to you before with the mnemonic A, B, C, D, E, F, G, H. All it does is ask about those things. So it's a very straightforward scale. So how do I interpret the PHQ scores? Well, here's the question of what are the total scores? If they're less than 4, it's not depression. 5 to 9 is very mild. A score of 10 to 14 is a moderate depression. And then from 15 and up, you start getting into the more severe, the more severe scores. So Riley can fill out the score by himself. Of course, you can ask him more questions, but you first on the initial screen find that there's a problem. It's probably internalizing. You do the PHQ and you see he falls into the category where he probably has a moderate to severe depression just by doing these 2 scales. Alternatively, there's also available the Columbia Depression Scale, and the DSM checklist are two others that will do the same job, but the PHQ is quite is quite simple, and in this kind of case, it will make the diagnosis. Now, when we try to assess psychiatric illnesses, it's very important to recognize that it's not enough to know whether or not someone has symptoms. We also need to know whether those symptoms are causing him dysfunction. Are they causing that person not to be able to work or to go to school or to play? And there's a simple thing called the CGAS. It's the Children's Global Assessment Scale. And it's really just, and it gives you different categories. So a 1 to 10 means somebody who is just very bad shape. They need constant supervision. From 35 to 45 is the upper limit of typical for a psychiatric inpatient, right? 50 to 41 is some interference in functioning, and 90 to 100 is superior functioning. So it's a scale that what you really do is you just put down a number. You start learning what some of the different categories of numbers represent. And it just gives you a way of discussing the case. You can say his CGAS was somewhere like 60, which means he's functioning a bit, but he's still having a lot of problems in the 60s. In the 70s, okay, that he's already functioning well. So it's a way of putting a number on your sense of what their functioning is. So let's say I did these two subscales and I interviewed him. I am now coming to the conclusion that he has a major depressive disorder. So if I've done that and I've concluded that, is there anything else that I should do? Well, it's very important now that I'm closing in on the diagnosis to make sure that there aren't other problems that are causing this major depressive disorder. Make sure that there's no substance abuse. Thyroid function can often be a cause of depression. So thyroid function problems can present as major depression. A basic neuro exam, making sure that you know what's going on with them in school. It's very important also that we take a trauma history for any patient that we're considering in terms of the diagnosis. People say, Dr. Amsel, you were talking about depression. Why am I interested in trauma? Well, in any of these kids that come in who have mental health problems, there's a good likelihood that there's trauma involved. Not always, but that's very important. You don't want to miss that. Okay, so these are the assessment summaries. As we said, you want to screen everybody 12 to 18. You want to assess depressive symptoms using the diagnostic criteria. You don't want to just use your intuition of saying this is a depressed child. And it's also important, even after those two scales, which are really your friends, these newly available diagnostic instruments make it so much easier and gives you so much more confidence that you're making the right diagnosis. But still, it's obviously important to talk to the child or the adolescent and to make sure that you get a good history so you understand what is going on with them, how they understand what's going on. So that even though these tools are excellent for helping us make a diagnosis, you wouldn't just use your stethoscope without talking to a child, asking them how their breathing is, how are they experiencing it. Same thing with this depression. You have to talk to the child as well. All right, so I think I hope that by now we've convinced you that even though you might be a primary care clinician and not having been diagnosing depression in your office all along, that by using these kinds of tools, these two-step tools, and doing an interview, you can actually come to the conclusion that, yes, I'm making a diagnosis. This child has depression. Well, what do you do then? Well, how do you treat depression? Well, contrary to what a lot of people think, the first order of treatment is actually cognitive behavioral therapy, especially for mild to moderate depression. For severe depression, we'll talk about in a moment. But the treatments available are cognitive behavioral therapy, and that's first order of treatment in a child or an adolescent, again, for mild to moderate. We also know that there's pharmacotherapy. The most common ones used are Prozac and Lexapro, for example. And then We do know also that there are newer studies that are coming in, especially for adults, but they're starting to get used in kids a little bit, but they're not yet approved in kids, and that's the transcranial magnetic stimulation, ECT, ketamine, and vagal nerve stimulation. Now those are being used in adults quite a bit, but not yet in kids. So you want to tell the family, explain to the family, I made a diagnosis. I think that your kids have a depression. And again, in the GLAD PC, there is a great discussion of how to talk to parents about this, how to make sure that they're on board, and that they understand it. And that's very important, especially here, because I know from some of the other talks here that there are many families in different sub-communities within Guyana, for example, where the family is not very sophisticated about mental health. So it's very important to educate the family. And then your next step is to say, okay, is this mild, moderate, or severe? And for mild, you really want to start just active support, monitoring the patient before starting any treatment. Just want to say, look, you're going through a difficult time. We're not going to start treatment until I see you back in a week and see whether or not your mood has improved. Because for very mild mood disorders, they often will change, especially in adolescence. They can have a terrible mood one day and really appear depressed, but a couple of days later, they can seem better. So for a very mild depression, you don't have to start treatment right away. You can watch them over a week or so and see whether they improve spontaneously. For moderate, we consider starting with, it says consider an SSRI or psychotherapy. We recommend you start with the psychotherapy if that's available. If not, then you can use the SSRI. What about the SSRIs? Well, in kids, we tend to use the SSRIs. There are TCA antidepressants and MAOIs in adults, but we tend not to use those in the kids. And here are the SSRIs that have indications, in other words, which the FDA has approved for kids. And this is a chart which shows what those are and how you start the dose and how you increase the dose. And if anyone really wants this chart, we can make it available to you. You want to start with a lower dose, of course, and gradually move up because you don't want to run into side effects right away. So you start at a low dose and you increase the dose over 1 to 3 weeks you increase in 1 to 3 weeks to achieve a full dose. If you're starting with Prozac, for example, you'd start with 5 or 10 milligrams, depending on the size of the child, and you gradually move that up. If they're having no side effects, you can increase the dose more quickly, but you don't want to do it too quickly because if you get side effects, the kids will tend to be non-compliant. Once the child or adolescent is on these medications and has gotten better, it's important to continue the medications because depressions will tend to come back if you stop treatment in the first 6 months. So the recommendations these days are keep your patient on for 6 months and then discontinue it very slowly, tapering only 25% every week. If you have a situation, we used to do this, well, we don't like kids on medication, we'd put them on medication, 4 weeks later, they seem great, and we've taken them off the medication. Turned out that 60, 70% of those kids would relapse. So we do want to keep them on for about 6 months. Also, if people have residual symptoms, if they don't completely get better, that's a greater a situation where you have a more likely chance of relapse. It's also very important to ask suicidal questions about suicidality, and perform a systematic and regular tracking of how well they're doing and any side effects that they have. And there are great questionnaires for doing this now, so you don't have to do it on your own. And again, the GLAD PC has those. There are lots of adverse possibilities with SSRIs, but most of them tend to be less common or rare, and the ones that are common tend to be short-lived and not so serious. But you need to be aware of this, again, aware of the side effects. You can reduce this by starting slowly. You can always reduce it. And also, I also tell my patients that most of these side effects will go away in a day or two. So when what's the conversation, you tell a patient, look, your body has to get used to this medication. Don't think that you'll have these side effects forever. If you have them the first couple of days, try to just get through the first couple of days. Most of these kinds of side effects will go away. Now, if there are some of the more serious things, that you have that are listed over here, of course, you want to stop the medication and do a thorough assessment. There is something called the boxed warning. It used to be called the black box warning, and that is that we know that for some of these medications, the boxed warning was put on there because there was some research studies that showed that when you start an antidepressant, kids will have higher rates of suicidal thoughts, not suicidal behaviors, but some suicidal thoughts. So it went from 2% of kids who were reporting suicidal ideation to 4% in these particular set of studies. But it's important to understand that even though in the beginning you might have that risk of increasing suicidal ideation, treating a depression definitely reduces suicide overall, because by taking away the depression, by reducing the depression, which is a major risk factor for suicidality, by treating it, you're overall seriously reducing the suicidality. Even though when you first start, you may have that increase initially. And so it's important to talk to the parents about this. Okay, just give me 1 minute to okay, so in summary, you want to involve and educate the parents and the youth about major depression. And here is another great website, parentsmedguide.org. Anybody want to just write that down? I'll leave the slide up for a moment. That will give you free handouts, which really explain it, and they're available in multiple languages. So these are very, very important. If a child comes into your office, you think they have depression, you go through this process. You do the screening test, then you do the more specific depression instrument, and you come to the conclusion they have depression. So you've got to tell the parents about this, and then you say, look, we're going to come up with a treatment plan, depending on how severe it is. If it's a mild depression, you just do active monitoring and support. If it's a moderate depression, you want to start with psychotherapy, with cognitive behavioral therapy. And again, that doesn't mean any kind of therapy. It's very important that you use a cognitive behavioral therapy, which is an evidence-based therapy. Kind of more traditional, just talk therapy has not been shown to be helpful in actual cases of major depression. But the specific cognitive behavioral therapy addresses the symptoms. And it takes about 10 or 12 weeks to do the cognitive behavioral therapy, and you tend to get very good results, not needing medication. However, if kids fail that, or if they come in and their depression is severe, then you definitely want to use an SSRI. And if the resources are available, there is no harm in doing both cognitive behavioral therapy and medication. And in fact, the combination will give you somewhat better results. The combination will definitely give you somewhat better results, especially it is more rapid in reducing suicidality. So that is an important, an important component. But either one alone also has very strong evidence that either one of those alone will help with treating this with treating the depression. And it's very important to recognize that you really, when if a kid is walking around with depression, it's not just that he has a bad mood. He's got a serious illness. The major depression is a serious illness, and the medications can be really startling how powerful they are to change it. A kid who's been walking around for months with a terrible mood, being very negative, having suicidal ideation, and a course of medication can change that in a very dramatic way. So don't underestimate the importance of that. I want to summarize also one more thing of going back to our this recommendation that we have for doing 2 sequential questionnaires. Let me just show you that again before we close out on this on suicidality. Yeah, that if you do these things, you do the PSE 17, again, kid fills it out, and then you can read this in like 2 or 3 minutes. And it's asking you all the questions that you would like to ask. It's asking that child all the questions that you would like to ask, and it will give you a score on these 3 really important dimensions. Does this child have inattention? Do they have externalizing symptoms? Do they have internalizing symptoms? And once you know that, you can hone down further. If it's inattention problems, you can use the Vanderbilt, which is his scores for ADHD. If it's externalizing, you can do these other scales, which tell you about ODD, which is oppositional defiant disorder, or other kinds of aggression, and it'll score those for you. But if it's internalizing, like in our case, you can do the PHQ-9 or the Columbia as a follow-up, and boom, 1, 2, and also these things score in moments. And 1, 2 screening tests, you've really come very close, very quickly to making the diagnosis and starting to be able to put together a treatment plan. I'm going to take a couple of minutes. We're going to go and do, there's going to be some redundancy in the anxiety talk. I'm going to start that in a minute, but I will take some questions right now if there's any questions from the audience.
Are there any questions from anyone? Dr. Amsel, the tool that you talked about, and I know it's probably aimed mostly at primary healthcare workers, but is it easily used by anyone, for example, teachers? Because, in our setting, you would find that, of course, it will be the teachers that will be with our adolescent population most of the time, and they might be the ones probably seeing some of the symptoms early on. So is this a tool that they could use, and if so, then what would be the next steps if they are able to administer this?
Yeah, absolutely. The scoring is, yeah, let's take a look here. Here's the pediatric symptom checklist 17, and it's available in different languages. Again, and it's free. And if you see what's happening here is it asks the kid, and if you think the kid can't report on himself, you could ask a parent to do this, right? But if the kid can report on himself, that's great. Okay, so look at the question asking you. Ask the kid, are you fidgety? That's one question. So is that never, sometimes, or often? Do you feel sad or unhappy? These are simple questions. And again, the child or the parent fills those things out. And look what you have here. You have this secret code, which is, if it's a diamond, then then you see why they do it this way. So the kid doesn't know what he's loading his answers onto. But you can immediately see, okay, for example, if we're going to look at internalizing, I can immediately see, okay, here's a diamond. Okay, he's got a 3 there. Here's a diamond. Here's a diamond. So first thing I do is I only look at the diamonds, and then I can see what's going on only with the diamonds. Then I look only at the stars, and that's the internalizing. Then I look only at the boxes, which is the externalizing. So I can do the scoring after you've done 1 or 2 of these. It literally takes no time. you can do that scoring. And again, you'll do the scoring of it and you'll see that, okay, the total score is 15. That means this child scored positive, which means overall they're answering too many questions with problematic behavior to think that, okay, the child is completely well, right? So over 15 will tell you that. And then you look at the subscales and you see, okay, so where is the problem loading on? So in this particular child, we see that the attendance is 6, which is less than the cutoff, but the internalizing was 9, right? So the internalizing scale was 9. You see that with the internalizing is the in this particular case, it's the stars, and those are, or the snowflakes. And you see, I've highlighted them in blue for you, so you can look at them very quickly. But once you've done the scale once or twice, you can do that highlighting. You just see it, you just see, okay, I'm looking of all the snowflake ones. Okay, my God, that's 9. That's more than the cutoff. So this child has an internalizing disorder. This child has, I don't know which internalizing disorder, but this child has an internalizing disorder. So then we're going to talk about anxiety later. If you think that the you see here's the case, that the internalizing number is greater than 5, then you say, child either has an anxiety or depression. If you have a reason to think it's a depression, then your next step is the PHQ or the Columbia Depression Scale, those two. If it's depression, it's the scared. We'll talk about that later. So yes, any teacher, I think anyone who is in a position, would I say that you need somebody with even with necessarily a bachelor's degree to do this kind of scoring? I wouldn't say that. I would say that an intelligent high school graduate who has some training, of course, some training and some supervision, right? Can score these instruments. Now, would I leave it completely up to them to make the diagnosis? No, but they certainly can sort out and say, okay, we saw, there's 50 kids coming into a clinic today, and of them, I looked at this scale, I looked at this scale, and 8 of them are suspicious for depression. Then a clinician would see them, right? But that initial triage using these 2 scales can be done, and it really, really increases efficiency, right? And can very, very much help with knowing where the more limited time that you have of the clinical person, right, can put their attention. I hope that answered your question.
Thank you, it does. Just out of curiosity, is there any more emphasis placed on any one of these factors, whether it is externalizing or internalizing? Is there one that is a little more important than the other that we need to pay a little bit more attention to? And then when we do the overall scaling, and say, for example, the child lands at 14, but they don't get to 15 or above, then what do you just observe and then retest within a certain period of time? Like what are the steps that we need to take there?
Well, again, yeah, that I understand that question. So again, 15 means that there is something significantly wrong. But if you get, let's say on internalizing, you got 9, 10, or 11, something like that, even though maybe they were 0 on everything else, you still would want to follow up and see, okay? So total of 15, that's for overall categorizing. But if any one of these scored high enough of over the cutoff point, you would want to look at that as well. You see what I'm saying? Each individual subscale is of concern. Even if the total is not greater than 15, if you cross the threshold for any one of the of these 3, that rarely happens. In my experience, usually they'll score greater than 15 if there's going to be scoring, because they have a few points in the other area. Does that make sense? Or did I just confuse you?
Oh, we have two questions from the audience here. I will let this gentleman go first.
I didn't finish answering your question, so let me finish one. I would say when you say is anything more important,
Right.
internalizing are very important, because that in the internalizing is where you're going to get the suicidal ideation, because of depression, a lot of anxiety, that loads on suicidality, right? So that's very important for that reason. The externalizing, you're going to get a lot of attention on that, even if you don't want to, because the externalizing meaning that child is hitting other people, the child is acting out, they're refusing to go to school. So in the externalizing situation, the parents will tell you, you got to pay attention, right, to this kid. You see the difference? And inattention is not so much an emergency, but it's terrible if you miss a child who actually has either a learning disorder, learning disability, or has attention deficit disorder, and they're sitting in class and unable to get anything out of it, because that will ultimately cause a lot of problems. So each one of these are important. I would say that the internalizing can sometimes be more correlated with an acute emergency situation. Okay, I'll take the other questions now.
Sure.
Doctor, starting to show I've been diagnosed with bipolar disorder for the last 20 years. I see myself as I would probably may resist like a questionnaire screening, but do you support a more tactical way of approaching a patient, like for instance, looking at the level of activity? Are they going out more often? Are they secluding themselves? Do you mood swings? Are they experiencing mood swings? And also observations by family members who know them well, or peers or teachers, or so to speak.
Yes, that's actually a wonderful question, and actually I'm going to give a whole separate talk on bipolar disorder. I think your question is very appropriate here, because we're talking about mood disorders, and I will give a whole talk. But let me answer your question now and to say, bipolar disorder is very rare. It's been very highly overdiagnosed in children and adolescents, very highly overdiagnosed. It's actually quite rare. So it's about 1/10 as frequent as depression. So it's much more rare. And the way that you see it is, it's very important to understand that bipolar disorder involves a manic episode. And a manic episode has got to be in a discrete time period. So if there's a child who he's always irritable, he's always hyperactive, then, and he's always getting into trouble and always overactive, that's not bipolar disorder. Bipolar disorder is there's a baseline, and the baseline changes. For at least 2 weeks, the child is acting differently, either more irritable, right, more angry, or they have an elevated mood. And during that time, they tend to be doing a lot more activity, not sleeping, they're overactive. They can be, very overconfident as well with themselves, like grandiosity. So it really manifests. It's really quite dramatic when you see a bipolar disorder in the child. The parents will say, "This is not the kid I know. It's different." So it's very important that there's a change from baseline when you diagnose bipolar disorder. I will speak of more detail on that in my talk tomorrow, which is at noon. So tomorrow at noon, I'm gonna cover bipolar and psychosis. Thank you.
Thank you.
Good afternoon. My question is, I'm a developmental psychologist. I'm more specialized with children and adolescents. And I heard you elaborate on medication for children, especially as it relates to depression. I am an advocate of not giving children medication because it can trigger other issues. So you might be a child might be taking medication for depression, but it triggers anxiety, or it triggers some sort of other mood disorders. Do you think that in rare cases that we should maintain cognitive behavioral therapy or some other behavioral therapy, and to avoid administering psychoactive drugs for children, especially with depression?
So the answer is, I would split. I kind of think I'll split the difference with you in the following sense. As you see in the our treatment thing, our first line of treatment, our first recommendation, except for severe depression, our first recommendation is do cognitive behavioral therapy. First recommendation is to do cognitive behavioral therapy for mild or moderate depressions. Precisely because of the reason that you said, we would prefer to avoid medication in children and adolescents if possible. However, the research indicates that for severe depression, it is important to give the medication. There may be some, of course, as you mentioned, there are some side effects, but the overall research in kids with severe depression indicates that not giving them the medication is worse. Leaving them in a severe depression leaves them at risk for suicidality, leaves them at risk for other medical disorders, for lack of caring themselves. So your overall approach, which is to say, I would prefer not to give a medication. We're on the same page with that. And I would say, get them to a good therapist and let's see if the therapy works. But either if the therapy doesn't work or if it's a severe depression, especially if there's some suicidality, then we believe it's better to give the medication, despite the fact that all medications have some side effects. All medications have side effects, but it is better to give the medication than to leave a child in the severe depressive state.
Are there any other questions from the audience?
So
just very quickly, if there are any in the chat before we move on, and we don't have any in the chat, so I will allow you to continue.
okey-doke. So we're now going to do you see my slide?
Yes, we can see it.
And it's full screen. It's a full screen slide.
Yes, it is.
Now, it turns out, as you're going to see, I'm going to go quicker through this because the assessment of anxiety is very similar. In fact, in kids, that's why we're giving these talks together. Sometimes, and it's hard to even separate the two, what they're different. They are different, but it's sometimes hard to separate. So you'll see that the approach is quite similar, so that we can move through this a little bit more quickly. So I've talked about the REACH training, and I want to thank them for allowing me to use their slides. I've been working with them, and I helped develop these slides, but nevertheless, they are proprietary REACH slides, and they have been kind enough to share them with this Guyana conference. So what we're going to do now for anxiety is very similar to what we did for depression. You'll see it's how to screen for anxiety, how to score the standardized screening tests, and how to discuss the psychotherapy and the pharmacology for anxiety, because like depression, there is both evidence for psychotherapy and evidence for pharmacology. So there's a real need. Again, remember that, the anxious kid and the depressed kid are going to look very much alike. So you can't rely on, not only can't you rely on kids' facial expression, you can't always rely on their being able to explain to you what their feelings are. Younger kids, even adolescents, will have a hard time. They know they're feeling bad, but they'll have a hard time telling you exactly what it is. So that's why, again, we're going to refer you to the GLAD PC, which covers all of these kinds of things. That's a great booklet, and I strongly recommend everybody download it and have it available. Well, what are the anxiety disorders? There's separation anxiety disorder. So this often shows up as school refusal, right? This child is afraid to be away from their parents. We have a very interesting study. We have 1,000 kids who went through 9/11, and we looked at them 14 years later, and we have a control group, of course. And it turned out that it wasn't so much that they had 14 years later PTSD. The thing that was the highest difference was separation anxiety. So people who've gone through a trauma can end up with separation anxiety. They're afraid to be away from a comforting other, from parents or a comforting other. Selective mutism, interestingly, is a form of anxiety disorder. You see it rarely, but you do see it. Panic disorder. Specific phobia means when you have a fear of something, like you fear snakes or bugs, or you have a real thing. Social anxiety disorder is when you're afraid of being judged by other people. You often, social anxiety kids, can't get up when they have a school conference and they're supposed to get up and give a little talk. They have a lot of trouble doing that. Agoraphobia is where kids are afraid of the agora or the marketplace. In other words, they're afraid of being in public. And generalized anxiety disorder, which is overall fear. Now, it used to be DSM-5 has done something funny. When I trained in my whole career, post-traumatic stress disorder and obsessive compulsive disorder were considered anxiety disorders because anxiety plays an important part in each of these disorders. But the DSM-5 has said, no, we're going to separate them out. Post-traumatic stress disorder is going to get its own chapter. And it's called, a chapter relating to traumas. And obsessive compulsive disorder, well, there's anxiety in it, but more has to do with compulsions. So they've taken it out of the anxiety disorder section and given that its own chapter. How prevalent are anxiety disorders? More prevalent than the depressive stuff. 8% of kids, of children and adolescents, and this is pre-COVID, and anxiety has gone up way more in the COVID things. We know anxiety has really jumped. What are the symptoms? Increased fears and worries about routine things in life, physical complaints. So sometimes the kid will say, I'm not worried, because kids can't, again, they cannot explain their emotions very well. So a kid may come up with you, a 9-year-old may say, I'm having stomach aches. When do you have these stomach aches? Oh, Monday mornings before school. That's when time that they have their stomach aches. So that's probably anxiety, school anxiety, right? It could also present as trouble sleeping or trouble concentrating. So it's not that they always will tell you directly that they have anxiety. So again, these things could be, think about different kinds of fear. Fear of social situations, of leaving home, separation from a loved one, school refusal. The other thing to think about is that anxiety disorders have a big developmental consideration. That means you may have different kinds of anxiety disorders in different age groups. Again, much more common among younger kids that their anxiety presents because they're afraid to be away from a caregiver, right? Later on, that may not be the problem, but their anxiety may manifest, in school situations. So it very much depends on the age as well. And you also, when you think about your differential, about what are things causing it, it can be psychiatric, which is what we're talking about, but also there are certain medical things, right, that can cause anxiety. And there's also substances that can cause anxiety. Especially a lot of the stuff that's over-the-counter stuff that older adolescents or middle adolescents or old adolescents use for energy. These things can cause tremendous anxiety. Okay, they're hyper-caffeinated. So here is a chart. I'm not going to go through every entry in the chart, but just to give you an example that in infancy, right. What is the inciting situation? Well, the parent leaving may cause them anxiety, because at that stage, object permanence is exactly the developmental skill. The child psychologist in the room will be happy to see this chart, because he'll see that we're paying attention to those kinds of developmental things. Language may be a problem there, so separation anxiety is going to be likely. In preschool, it's much more problem with executive function emerging, expressive language problems maybe at that thing. What about in middle school, right? Well, there you're starting to have social demands. So performance anxiety can come out. you're transitioning from home to the larger community. If you're having any problems with cognitive skills, you have a reading problem or something, that can cause the anxiety at that age. So this gives you, an example of the different ways that an anxiety might manifest itself, depending on at every developmental age, there's a developmental challenge. And if you're not meeting your developmental challenge, that could be the source of your anxiety. Again, in speaking to those in the primary care setting, pediatricians and such should be aware of this. People, should be aware of this. Very often, you will have some of this information. For example, a psychologist will have be able to refer, hopefully, to the pediatrician who last saw the child and say, are there any medical problems? This child is coming to me with an anxiety disorder. Do they have any of these kinds of things? Do they have asthma? Do they have seizure disorders? Is there anything that I'm not aware of that might be causing the anxiety disorder that falls into the medical sphere? So just to be aware of that so that you're not missing something. What is the differential for anxiety disorders? Well, attention deficit hyperactivity disorder. If there are kids who have ADHD, they're not aware they have ADHD, they can be having a lot of anxiety because they're not able to concentrate and follow what's going on in school, and they're starting to fail out of school. The teachers are calling, are calling them out a lot, and so it could look like anxiety when it's actually attention deficit disorder. Very, very rarely you'll have psychotic disorder in a young child, and that child may be hearing voices, and so he'll come and he'll say, "Oh, I'm very anxious. Something wrong is going on," but will not be able to express it. We're very interested in paying attention to whether or not we have autism spectrum disorder going on, and if the parents are unaware of that, the child again may present with anxiety. A learning disability. If you have a reading disability, you're a child and you're in class, and all your peers are being able to read, and they're starting to read, and you're having trouble reading, and you're not aware of why you can't do it, but the other kids can do it because no one has established that. Oh my God, you have a dyslexia, and that's the reason you're having trouble. That child just may be very nervous. Mommy, Daddy, why can't I do it? The other kids are doing it. As mentioned by one of our questioners, bipolar disorder should be something to think about. Okay. So again, I want the other things. Again, the reason we want to talk about these things is before you come to a conclusion, think about all the other things that could be part of it. Substance abuse, adjustment disorder. We always want to ask about abuse and bullying. If that's going on, because kid comes to you and they're suddenly agitated, they're upset, and it feels like, oh, it's an anxious kid, but actually what's going on is that there is abuse going on and they're afraid to tell you about it. So important to be aware of that. So to summarize this chart, I would say, be aware of any medical problems, any drugs, and any trauma. Medical problems, drugs, and trauma that may be causing the anxiety. And so it's not really primarily an anxiety disorder, but it's caused by one of these other things. One good mnemonic is for asking questions is you can ask a child what's called colder, C-O-L-D-E-R, colder. It's a mnemonic which, what are the when you say you're anxious, tell me what it's like. That's the characteristic. When do you get this anxiety? When do you get the anxiety? Where do you have the anxiety? Do you have it in school, only in school, but you're real comfortable at home? Or is it only at home? If it's only at home, then you're thinking more, maybe there's some neglect or abuse. If it's only in school, you're thinking about some learning disability. How long does the anxiety last? Exacerbation and relief means what makes it better, what makes it worse, right? Well, yeah, it's only in school. It only happens in school. And if I'm sitting next to Jimmy, he's my close friend. If I'm sitting next to him, then it tends to go away. But if I'm not sitting next to Jimmy, then it's worse. So those are the kinds of clues. The colder things are the kinds of clues about the specifics of the anxiety that will help you understand the contextual factors that are going on with this symptom. So if you have the impression or your screening says maybe this is just as we did before, maybe this is anxiety, then you want to think about which anxiety disorder is it, how severe it is, and how it's getting in the way. So let's see how this goes by using a case again. So Sue's an 8-year-old girl, 3rd grade. She says, I have stomach aches and I feel uncomfortable with my peers in school. She's also tense when her parents discuss the schoolwork, right? Parents are very demanding of her. She has no stomach aches on the weekends. Remember the colder? So the location of them and the time of them is very telling, right? These stomach aches are happening are not happening on the weekend. That starts telling you that maybe this is related to, it could be related to different foods, of course, as well. Maybe if during the week she eats, but most of the time when you hear it, stomach aches are not on the weekends. It's a clue that this is a school-based thing. So here are the symptom checklist as we talked about. It's again the same PSC that we talked about before. When I give these talks separately, I have to go think, but I've already laid these out for you. So the first thing I would do is say, I want this child to take a PSC, and this is what she does. Sue took the PSC, and here's what came out of it. She has these 3 scores, right? She has a 6 on inattention. She has a 0 on acting out. She's well behaved, but she has a 9 on internalizing. Remember, we had a 9 before on internalizing, but that turned out to be depression. So the 9 here could be the 9 on internalizing can be either she's passed the overall score of 15, so she scores in positive, and in the subscale, the 9 means that she's positive for internalizing disorder. Remember how that thing goes. 9 for internalizing disorder, nothing for externalizing disorder, and she's right on the border when it comes to inattention. This is going to be a review because we are a very, very parallel process when I'm looking at depression or I'm looking at anxiety. We had the attention subscale, and she saw something on this. Here it is. It's a 6. It's below. The externalizing subscale, she was totally 0 on the externalizing. This is not a young woman who acts out or is a behavior problem. But on the internalizing questions, let's look at the severe ones for her. She feels hopeless, down on herself, and worries a lot. Okay, so just to review, total of 15 score, attention subscale, internalizing subscale is a 9. So what do I do now? But the way she's talking about it, I'm not hearing depression. So this time I have the internalizing, and which one do I go for? Not the PHQ-9 or Columbia, because those are for depression. I go for the next scale, which is the scared, and the scared scale down here, screening for child and adolescent. The scared scale is my next. This is all repeated from before. My scale will give me much better answers about anxiety, just like the PHQ will give me the answers about depression. The scared will give me answers about anxiety disorders. 8-year-old child and older can fill it out. Although from 8 to 11, it's important that the clinician explain the questions to the child, or that the parents does it from 8 to 11. Below 8, it's the parents should fill it out. Now this one's longer. It's 41 items, and you score them as no, sometimes true or very true, and then a score of over 30 is more specific. So in this one, again, you have these subscales. The person goes through and answers all of the questions, but then they have a way of assembling them. And you'll see there's some automatic ways of doing this, just like there were with the other one, although this has more it has more questions you have to look at, but a score of 7 items out of these indicates panic. 9 items out of these are generalized anxiety. 5 items are separation. So depending on, you have these subscales, depending on how they answer the subscales, I can start to sort them out between school avoidance, social anxiety, the different subtypes. And the scale itself looks like this, just straightforward questions, but you will see the scoring is all written down for you. So you don't have to memorize or anything like that. The scoring is all marked down here, and you simply look and see where do the positive scores load on? Do they load on which one of this subset of scores, right? So Sue scored a total of 32, which is greater than 25 and greater than 30. So 25 is the absolute cutoff. 30 is an even stronger cutoff, which means very likely an anxiety disorder. Notice that in the subscales, she had significant school avoidance with a score of 8, significant generalized anxiety, and for panic and somatic, she also scored high. For social anxiety, she didn't score high. She is not a child who's afraid of other kids. She's not the most popular kid, but she's not afraid or uncomfortable with other kids. And she's not particularly uncomfortable when she's away from her parents. In fact, her parents are the ones who are creating the school pressure on her, right? So they're not the source of her anxiety. So look, I just wanted to say, look how much I know about Sue just from this, right? It's not just that I know that she doesn't have separation. I go, oh, that's interesting. She's fine being away from her parents. She's not afraid of things. She has friends. She's not afraid. She's not socially anxious, right? But the school thing is important. She has real school avoidance. That's going to cause her to have a lot of anxiety if she's spending a lot of time in school. And then she has physical symptoms. You see, panic disorder or somatic means that her anxiety is manifesting with a stomach ache. So, wow, this is a really great instrument. It really gives me the picture of Sue's situation, and it corresponds very much to the story that I gave you about her. And that's when you start realizing how good these scales are. When the clinical story, you got the initial clinical story, and then that matches up so well with the questionnaire, then you can say, oh, now I really feel confident, right? Her story fit with this, and the questionnaire fit with this kind of situation. So I get a very good confidence that we're going in the right direction. This slide simply tells me that, again, the kinds of things we mentioned before, it's very important. Even when you have these scales, and you've done these scales, it's not enough just to do the scales. You need to talk to the child and to the family, ask them what's going on. Say, oh, these scales seem to indicate that you're very uncomfortable in school. Tell me a little bit more about that. Okay, so you want to do a complete assessment. You want to make sure that you're talking to them as well as doing the scales. But I think, as I've showed you, the scales can be so helpful. We have a special slide now because in the last few years, there's been much greater emphasis on making sure that I always ask about trauma, neglect, and abuse. And so we're going to take a little diversion and talk about that. 1 in 4 children have some kind of traumatic event. So you want to look for exposure symptoms, and you want to look for exposure and symptoms. So you want to look what has happened to this child. Has anything frightening or dangerous happened to you? Anything frightening or dangerous ever happened to you? I think that's a comfortable question. You certainly don't want to ask a child, is daddy beating you up? I mean, just say, has anything frightening or dangerous happened? And then you can see if a child becomes very uncomfortable and is not answering your questions, back off and try to get information in other ways. So in addition to trying to find out what the exposure was, you also want to look for what are the symptoms, any changes in behavior or mood, or anything else that have suggested that these are the long-term effects of some trauma that may have happened in the past. So we're familiar that traumatic stress the kinds of symptoms you have are re-experience, avoidance, and hyperarousal. Those are the three baskets of kinds of symptoms that you can have, right? Re-experiencing shows up in nightmares. Avoidance is kids are afraid of certain kinds of things. And hyperarousal is kids are very vigilant or irritable. And those are the kinds of things that you want to make sure to look at in terms of trauma. Whether you're looking at anxiety, even though if anxiety disorder is your first in your differential and you think that's the most thing, as in the case of Sue, we really think that's the major thing going on with her. But I wanted to remind you that in those cases, always look for trauma. What about the treatment of anxiety disorder? You'll be happy to know again that there have been a lot of studies with kids and with adolescents showing that cognitive behavioral therapy is the first line of treatment. And that is our first recommendation. There are some cases when a medication is indicated. So I hope people are familiar with what CBT is. CBT involves psychoeducation. It involves cognitive restructuring, talking to the child about the things that are afraid of them, challenging their fears. Sometimes it involves exposure. Exposure therapy means I expose gradually and carefully. I expose my patient to the things that they're afraid of. And by that exposure, they learn that they are safe in that situation, right? So that they can learn that they're safe in that situation. After 9/11, I was heavily involved with treating the firefighters who were caught in 9/11. We had lots of firefighters who developed PTSD and they couldn't get into an elevator. They were terrified of elevators, which meant they couldn't do their job. So we did a lot of exposure, which meant I would go and I would stand gradually. First, we would stand like 5 feet away from an elevator and would stand there, and the firefighters, their anxiety would go up. But if they didn't run away and if they stayed long enough, the anxiety would come down and they would learn to tolerate it. And then we'd get closer. Then I would just ask them just to push the button. So you do stepwise, and you let the anxiety rise and you let the anxiety will eventually come down, and that's called exposure. And as many of you know, that's the treatment of choice right now for PTSD. For simple phobias, like if you're afraid of a snake, that's the way to overcome it. Fear of flying. Years ago, there were a lot of activity in which therapists were actually flying with their patients. The patient had to travel to Europe and couldn't go on an airplane, so the therapist would take a short flight with them from one city to the other and sit with them as an exposure therapy. So I've spoken about exposure. So exposure is what I just talked about, is the live exposure. There's also something called imaginal exposure. Imaginal exposure is where you expose yourself to memories. So you ask somebody to go over a trauma that happened. What is the trauma that happened? Go over it in detail. That's called an imaginal exposure, because they have to relive the trauma in the office. And again, because they're doing it with you, even though it brings up their anxiety, eventually, if they do it over and over again, which is what you have them do, it starts being less scary. Cognitive restructuring is that part where I explain to people that there's how their fear system works, explain how the fear system works, and help them change their thinking about them. Especially a lot of people with anxiety have what's called catastrophic thinking, which means they always think of the worst case scenario, and you challenge them. You say, you're only thinking about the worst case scenario, but is that realistic? So that's always very helpful. And somatic management means that anxiety disorders, although they're in your head, they're often also in your body, right? When you're very anxious, your heart rate is going fast, you're breathing quickly, you're sweating, right? You're getting change in conductance, skin conductance, all these kinds of physical things are happening simultaneously. So it's very important to address the physical things as well. deep breathing, meditation, systematic relaxation techniques can be incredibly helpful. Because if you can get your body to calm down, the body will signal the mind to calm down. So there's somatic management skills. Just a 5-minute breathing exercise. I don't know if you guys are familiar with John Kabat-Zinn, who really made these kinds of exercises very popular in the States, and others who have done quick breathing exercises can make a huge difference in anxiety disorders. So CBT involving these elements, this is the first line of treatment, not drugs. Okay, those are the treatment resources. So going back to the previous gentleman's question, we hate to give medications to kids, but is there ever a time where you do want to give medication to kids? Again, mild severity should not use medication, do psychotherapy. What are the valid reasons for introducing it? If there's a need for acute symptom, if a child is so anxious that they're jumping out of their skin and they can't tolerate it. If they have a comorbid disorder, for example, if the child comes in with anxiety and depression and they actually score for both of them, that might be a reason, okay? If they tried the therapy, they didn't get a good result out of a good course of therapy. These are all the reasons that you might decide that you're going to introduce medication. Again, even though your first choice is the therapy. What are the FDA approved medications? This is in the United States, of course. I'm talking about the American FDA. And they've done studies that justify the use of SSRIs, fluoxetine, fluvoxamine, sertraline, Prozac, Luvox, and Zoloft for kids down to the age of 6 if they have OCD symptoms. For generalized anxiety disorder, duloxetine is improved. And here are some of the studies. So there's the RUP study, the Pittsburgh study. I'm just going to talk about one example. These are a number of studies. Also in answering the question, have these medications been shown to be safe and effective in kids? Well, in the RUP study, for example, they compared fluvoxamine and placebo in kids with social anxiety disorder, generalized anxiety disorder, and social phobia, and they found that the medication was better than placebo. That wasn't a comparison with with behavior therapy. The Pittsburgh study had a similar finding. Now down here in the POT study, you see, they compared what happens if we do combination cognitive behavioral therapy and medication, compare that to only cognitive behavioral therapy, and compare that to only medication. So look what happened. The combination was best. CBT combination therapy was best, and that was better than CBT, but CBT and sertraline were equal. So the cognitive behavioral therapy and the medication were of equal help in the anxiety disorder, and everything was better than placebo. So I don't want to go through every single study. They have this, most of them have the very similar results. The CAM study is just the same thing. It has a much larger sample, but you will see that if you look at it, you had that same interesting result. The combination therapy, 81% had a response rate that was better than CBT, which had a 60%, but that was equal to sertraline with a 55%, and those both were better than placebo. The take-home message is that in most kids, in the majority of kids, 60% of them, CBT will do the trick, and you can avoid the medication. But there are some kids, 40%, who do better on the sertraline. So some of them didn't do well, but the psychotherapy is better as a first line. So when you start these medications, it's importantly to start low and go slowly, as we mentioned before. Expect improvement in 2 to 4 weeks. It doesn't happen right away. That's one of the big challenges with medication treatment, is it's slow. And here is a chart of the different medications that can be used in anxiety disorder. And yeah, this is just a challenge. If anybody would, after a careful assessment of Sue, if she didn't do well with therapy, what medication would you use? And this is a challenge that we do when we teach some of the pediatricians, and many of them said if she failed, the therapy didn't work, or in many places therapy is just not available. You have a kid who's extremely anxious, no therapy is available. Will you start meds? We recommend, if that's all you have, then yes, the child is better off on meds if they can't get therapy and they're not getting better on their own. So what about benzodiazepines and other anxiolytics? These are oftentimes seen because this will give you immediate relief. We do not recommend that you use these in child and adolescents. There's no evidence to show that benzodiazepines or beta blockers are good for kids with anxiety disorder. Oftentimes you feel pressure to do this because these medications can give you immediate relief, but that relief is a Band-Aid. That relief is not treating the underlying disorder. Only the cognitive behavioral therapy and the medication does. So all the evidence is that the benzodiazepines should not be used, except there are some emergency cases. There are some emergency cases where, for example, if a child has severe panic attacks and is having a panic attack every day, and you decide that they do need, let's say you decide that they do need medication because it's so severe and happening all the time, well, the SSRIs are not going to kick in for a couple of weeks, and this kid is having a panic disorder every day. So under that kind of a circumstance, you can start with a benzo, you can start with something like Ativan or like a Xanax, but very shortly, just use it for those 2 weeks until the true medication, the SSRI, kicks in. So it's just a bridging medication, but otherwise we discourage that kind of use. So what is the summary? If you're a primary care doctor, look out for anxiety. It's very common. Remember, 8% of all kids are going to have this pre-COVID. Pre-COVID and in a relatively comfortable society like that in America, 8%, right? So relatively comfortable, less hardship than in a lot of other places. And it's still 8%. There's a lot of comorbid disorders, so make sure that you're thinking about other kinds of things that might be going on. Maybe the kid's using drugs, maybe he or she has ADHD. Use the SCARE tool. I mean, start with a PSE and then decide if it's internalizing, and then use the SCARE tool to follow up. Once you've made your diagnosis, use CBT and SSRI only secondarily if you have to, depending on the severity. The good news is that if you diagnose it correctly, explain to the kid what's going on, explain to the family what's going on, and they're able to get to a therapist or a therapist substitute. And what I think we have to talk about, that's one of the things that the Ghana Wellbeing Study is talking about, is someone asked me who could do the diagnosis. Well, you know what? People can be trained to do the cognitive behavioral therapy if a child is, well diagnosed and there's the supervising clinician. Some of these treatments can be delivered by what we call professional extenders. So the good news is anxiety disorders are highly treatable. And boy, when you have a kid who has a severe anxiety disorder and you are able to make that go away, you have changed that kid's life. They are so grateful. They are so much better. The diagnosis is doable, the treatment is doable, and you have very good results. I think here's a resource slide, and we have questions. We have a few minutes for questions. Thank you for your attention.
Dr. Amsel, thank you so much. If you could just give him a round of applause for his.
Okay, we have no time for questions. We're out.
We have 2 minutes for questions, if there are any questions in the audience. Yes, Dr. Grant.
Good afternoon. Thank you for your presentation again. We have been trained to use the GAD-7 questionnaire in children. I don't know if we were right in using it with children. I saw some allusion to it in your presentation. But I didn't see as a salient questionnaire used with children and adolescents in your presentation. What are your thoughts on that?
Yeah, my thoughts are, again, when we do these things, we give you sort of examples. We like the PSMD, we like the SCARED because it sorts out some of the different things, but the GAD-7 is a wonderful scale, right? And even though it's called GAD, it's about generalized anxiety disorder, it will score for you any anxiety disorder, right? It'll score panic disorder. And if you get a high score on that, if you get a positive score on that. The only disadvantage is it tells you the kid either has GAD or they have another anxiety disorder. Most likely it's GAD because that's in some ways that's the most common one. It won't break it down to sub disorders, but that's in some ways that's a luxury. Defining which sub anxiety they have, knowing that they have anxiety for sure, which is what you're going to get from the GAD is often, enough, because in terms of making your decision, this child has to get into treatment. This child doesn't. The GAD will do the trick for you, right? It'll make that help you make that clinical decision as a decision support. So I teach this one because GAD-7 is easier and people use it. This one we like, but GAD-7 will work just as well in most cases.
Thank you again, Dr. Amsel. I really like these tools that are quite simple and can be used at the primary healthcare level. We have one last question from the audience here because of time.
Okay.
Mine is not a question, it's just a comment that we are expecting all the presentations to be online on our site. The only thing is, and UG is really helping us out. They have a lot of things to be done from now to Christmas. So they promised us that by January, we should have all uploaded. So that if you want all the presentations, you don't need to bother, you will get it from online from our site as from January.
Thank you.
That if we're able to pay for someone to work, someone paid, we can get it within a week. So any one of you wants to need some money, we can get it.
Okay. And also, I'm going to talk. So tomorrow, I'm going to talk about primary care, doing a suicide assessment in primary care, and I'm going to talk about bipolar disorder and grief tomorrow as well. So if anybody here thought that these were useful, there's 3 more talks tomorrow. Thank you so much for coming and for participating and for the active questions. I really appreciate it. Everybody have a lovely evening.